Hi, my name's Haven Campbell, and this is for my respiratory 2480 class. And today we're going to be continuing the talk about chronic obstructive pulmonary disease, or COPD. So we're going to be talking about the pharmacologic therapy for our COPD patients. So pharmacologic therapy for COPD is used to reduce symptoms, reduce the frequency and severity of their exacerbations, and improve exercise tolerance and health status. There are many types of medications that can be used for COPD patients, and that can be tailored to fit their specific needs. So the main one and the most big one and most common one is a bronchodilator. This is a medication that can increase their FEV1 and or change other spirometric variables. These medications are known as your beta-2 agonists. The principle of action for a beta-2 agonist is to relax airway smooth muscles by stimulating the beta-2 adrenergic receptors. There are short-acting and long-acting, which are abbreviated your SABAs and your LABAs. There are also antimuscarinic drugs. So these help block the bronchoconstrictor effects of acetylcholine in your body on muscarinic receptors. There are also short-acting and long-acting, your SAMAs and your LAMAs. So your short-acting for like any drug can last anywhere from about 4 to 6 to 8-ish hours. And your long-acting drugs can last anywhere possibly from 12 up to even 24 hours. Clinical trials have shown a greater effect on exacerbation rates for LAMAs treatment versus LABA treatments. So some of your COPD patients are responding better to your antimuscarinic drugs than your bronchodilator drugs. Another drug category that they can be put on is a methylxanthine. There is some controversy about the exact effects of xanthine derivatives, but there is evidence for a modest bronchodilator effect compared with a placebo in a stable COPD patient. So when they do testing on this, one patient will take this methylxanthine drug and another will take a placebo, and they will test kind of the differences and see. So there is kind of a modest, a slight effect of the methylxanthine compared to a placebo. A combination bronchodilator therapy. So combining bronchodilators with different mechanisms and durations of actions may increase the agreed bronchodilation with a lower risk of side effects compared to increasing the dose of a single bronchodilator. So instead of like upping the dosage for one single medication, they will try to put you on like a combination of both to get a desired effect. So that could be like a short-acting bronchodilator and a short-acting muscarinic, or any type of combination is sometimes better than just one medication alone. A lower dose twice daily regimen for a LABA and LAMA has been shown to improve symptoms for health status in COPD patients. So maybe that would be such as like taking a lower dose twice daily. So if they have like an inhaler, instead of taking such of a high dose, they'll take a lower dose, but twice daily. So that could be 2 in the morning, 2 in the evening. And that helps them with their symptoms throughout the whole day and even the night. So anti-inflammatory agents. So today, exacerbations represent the main clinically relevant endpoint use of efficiency assessment of drugs with an anti-inflammatory effect. So whenever you are kind of going through an exacerbation and those bronchioles are swelling due to that tightness of that smooth muscle, there is inflammation. So an anti-inflammatory drug could help with that. So inhaled corticosteroids. In vitro evidence suggests that COPD-associated inflammation has limited responsiveness to corticosteroids. Both current and ex-smokers with COPD benefit from corticosteroids use in terms of lung function and exacerbation rates, though, although the magnitude of the effect is lower in heavy or current smokers compared to light or ex-smokers. So if you're, still currently smoking, or have just kind of like recently stopped, you're not going to see a bigger effect than someone who is not smoking anymore, or they are very lightly smoking. Inhaled corticosteroid treatment alone has shown that regular treatment with inhaled corticosteroids alone does not modify the long-term decline of your FEV1 nor mortality in COPD patients. Corticosteroids in combination with a long-acting bronchodilator is more effective than either component alone in improving lung function, health status, and reducing exacerbation. So this is kind of normally what you see being combined together, an inhaled corticosteroid and a long-acting drug, because you're killing two birds with one stone. You're getting that corticosteroid relief, but also you're getting that long-acting that's going to last you all day. So some factors to consider though when initiating inhaled corticosteroid treatment with like a long-acting bronchodilator. So some strong support is history of hospitalizations for exacerbations of COPD patients, greater than 2 or more moderate exacerbations per year. Your blood eosinophils are increased up to 300, and a history and of asthma. You want to consider the use if a patient has 1 moderate exacerbation of COPD exacerbations per year, and your blood eosinophils are in the range of 100 to 300. And you do not want to use them if you have repeated pneumonia events. Your eosinophils are in the 100 range, and a history of myobacterial infections. So those are just factors to consider when initiating inhaled corticosteroid treatment steroids. Okay, so triple therapy. This would be your LAVAs, LAMA, and an inhaled corticosteroid all in one. So this is what you'd be taking if you started triple therapy. So to step up the inhaled treatment of your LAVA, LAMA, and an inhaled corticosteroid can occur by various approaches. It has been shown to improve lung function, the patient reported outcome, and reduced exacerbations when compared to each medication alone. So when taking all 3 of these, they have improved lung function, and their amount of exacerbations is reduced. Together, these results suggest a beneficial effect of fixed dose triple inhaled therapy versus fixed dose of a LAMA and a LAVA combination on mortality in symptomatic COPD patients with a history of frequent and or severe exacerbations who are previously receiving maintenance therapy. LAVA and an inhaled corticosteroid or single or dual long-acting bronchodilators. So pretty much they're benefiting from taking all 3 of these than taking such of a LAVA and a corticosteroid or something like that. So taking all 3 of these is benefiting your COPD patient. And this is just kind of a chart of all the medications that they can take. It just kind of breaks it down a little bit easier. So your beta agonists, this is like your bronchodilators. Your short acting or your SABAs would be like your albuterol, your levalbuterol, anything like that. Your long actings are your formoterols, alphamoterol, anything like that. So that's where you're getting your short acting. So like your rescue inhaler that only lasts about 4 to 6 hours. But then you can take a long acting, which can last anywhere from 12 up to 24 hours. Your anticholinergics, these are your SAMAs and your LAMAs. So your ipratropium bromide can last anywhere from 6 to 8 hours. That's what you see a lot of your COPD patients on. And your long actings, some of these are even lasting up to 24 hours, which is great. And then you have your short acting combo drugs and your long acting combo drugs. Then you have your methylxanthines and your combination of long acting plus your corticosteroids. One of the big ones I always see is this salmeterol and the fluticasone, formoterol and the budesonide. Those are some pretty common ones. And your triple combination in one device. So this is having all 3 in one device. So this is kind of where they really benefit, is having all 3 of these. And then you even have your mucolytic agents. So when COPD patients, they do produce like a large amount of sputum, and sometimes it does become hard for them to cough it up or get it out, which reduces their lung function and their ability to breathe. So they can be prescribed one of these, which will help thin those out so they can cough them up. So that's just a little bit about the different types of medication a COPD patient can be on. There is a million different combinations. They're going to fit medications based on the patient, so whatever works better for them, and it helps reduce their exacerbations and helps them breathe easier.